All right. Today we are going to talk about how to go out of network with Anagram. We're going to jump into a product demo so that you guys can see the system for anybody here who's new and hasn't seen Anagram in the past, or for anybody that needs a refresher who may have known of us or checked us out back when we were Patch. Over the last 4 years, we have added all kinds of features into the system. We've changed our name from Patch to Anagram simply because we are growing up and we wanted to make sure that our brand reflected the direction that we were growing in. And so it's been a really exciting last 4 years. We now have thousands of people on the system that we have helped either bridge the gap for who they were already out of network with, or helped people in particular drop plans that were no longer serving them. So we'll talk about both use cases today, but we are going to stay focused on how to make the leap of faith and start to operate an office that is not bound by vision plans. So let's jump in. My name is Jenna. I have been here for the entire duration of Anagram's life cycle. It was really exciting getting started 4 years ago when everybody just thought when you were out of network, you were out of luck, that there was no way to be able to assist those patients because the insurance companies made it so challenging. Over that time, being able to educate people, help them understand that we have put our blood, sweat, and tears into this system just simply because we think it is the right thing to do. Patients have a right to know what their insurance covers. Doctors, opticians should be able to easily access that information for the sake of the experience, to provide that transparency and to empower them with knowledge. We all know that when people have an understanding of how much money they have, they're going to be more likely to spend it in ways that make sense for them. So it's been a wild ride being able to re-educate this industry that was really overtaken by all kinds of myths from, well, IMED doesn't offer out-of-network benefits. And, if you submit, it can only go to the patient. And when the patient calls into the phone line, the insurance company rep is always going to try and intercept your customer. Really working through all those misconceptions that were perpetuated by the insurance company because there was no middleman there to call them out or hold them accountable has been a lot of fun, to say the least. So it's important to keep in mind that when we talk about dropping vision plans, it's more than just pulling the plug, implementing Anagram, and letting the program do the work for you. We really need to consider this starting a new strategic business. Out of network patients are essentially cash pay patients, right? So when you are no longer relying on the vision plans for their search portals or their marketing acquisition, which is essentially their fee schedule every time a patient comes in to see you, you have to be proactive in how you're engaging with these patients so that, first of all, they know that just because you don't accept their plan anymore, that it doesn't mean that you can't see them and can't get them access to their coverage. But also for new patients, that they still have the ability to find you, and that you aren't advertising yourself as, I don't work with any insurance, because patients will then assume that that means their benefits will go wasted in your office. So being really thoughtful on how you start to market yourself using different platforms like Facebook, Google, Yelp, opportunities that present and promote your reviews can highlight the fact that you have made this decision because it really is in the best interest of your patient care. You want to be able to use the labs that you love and offer the products, the materials that make best sense for your patients, let alone not be held hostage to these super low fee schedules that then require you to inflate your costs, continually upsell them. Many people in certain circumstances, if they're dealing with a Davis or Spectera, if the patient comes in and says, I just want what my insurance covers, the practice can even lose money in that scenario. So now you have your opticians on the floor constantly trying to find ways to upsell, and then also managing expectations that, well, because you're a Davis patient, I'm going to have to send this to a Davis lab, and hopefully your prescription is right, and hopefully it doesn't take 3 months for you to receive that order. All of it causes a lot of work on the front end for your staff to be able to manage how patients understand how their insurance works. Uh, Truth is when you go out of network and you're no longer on their search panels, you are going to take a hit in volume. Many of our customers over the last 4 years have seen that when they drop a plan that has a lot of covered lives in their office, they'll see a decrease of about 15 to 20% in overall volume. But those patients that they're losing are typically the ones that say, I only want what my insurance covers. And again, we know that those patients don't actually bring much value to the practice, and ironically oftentimes end up being the ones that have the most complaints, that need the most handholding, and are likely to then go onto your website and leave a negative review when it does take 3 months for them to get their Davis prescription. And they're really blaming the middleman because, again, they don't understand that your hands are tied when you're in network and you don't have the choice to send their prescription to Cherry. You have to do what their insurance dictates. So, as we think about dropping insurance, taking all these pieces into how we're communicating to patients is critical. And that's where, really thinking about the script and all of those things, which we'll talk about a little bit more in a second, is really important. Now, couldn't be more grateful or blessed to have everybody on this call come through. My personal favorite partner of ours, Cherry, has been an ally of Anagram since day one, mainly because they know as a fully independent lab that quality counts, and that when you aren't bending over to work with every single person because you're playing the volume game, you have the opportunity to take the absolute best care of your customers. And so, one of the huge pulls for everyone in this industry is that when you have a cash pay patient, it's actually feeding the entire ecosystem of vision care for the highest good, right? Labs, independent frames, lenses, all of those systems that are going to impact how patients perceive care in your office can have a better experience for you guys on the back end when they're not jumping through all the hoops of these vision plans. And so together, the altruistic goal of both Anagram and Cherry is what's best for the patient, what's best for the practice, what is best for vision care. And it is true that power does come in numbers. And when you have the opportunity to say, hey, I'm going to make a pivot, I don't need to pay to play this quantity versus quality game anymore. Because really, that's what the insurance companies sold this industry 40 years ago when they got started. They said, hey, we're going to cut how much we pay you per patient, but don't worry about it because we're going to send you so many more patients that the volume will make up for the drop in what you're making per exchange. Over time, that pitch essentially falls on deaf ears because not only in lieu of COVID are we not allowed to jam pack our schedules with 30, 40 patients every day because it's not really safe as an office practice for our staff or for our patients, but also then as providers, you guys don't ever have enough time. Maybe you spend 15 minutes per patient. You don't get to have that same personal touch. Maybe you're working one day a weekend. And there's such this, hamster wheel feel that comes with getting every single patient possible in your practice, but not focusing on the quality of those patients. The point when you go out of network is that you're going to actually be able to increase the value of each patient, spend more time with them, and that will not only be reflected in how patients perceive care in your office, but how you can perceive your overall quality of life in this career, not feeling like you have to work, be open from 8 to 8 every day in order to see enough patients that the overhead starts to make sense. Many of our practices over the years that have used us to drop insurance come back continually and say their favorite part about it is that they now know every time they see a patient that they can spend as much time with them, that they don't have to worry if the math and the cost their chair time is going to make sense because they know that it will. And I think overall, whether you're, on ODs on Facebook, opticians on Facebook, and everybody has so many complaints to make about what it feels like, when you're running an entirely vision plan driven practice is that we want to give you the opportunity to say, hey, you know what? I don't want to work Fridays. I want to work toward retirement. I want to make it easy for me to even think about having my practice acquired someday because the value of revenue I'm bringing in year over year is growing, but I'm not having to continually fill my practice with these vision plan patients that don't appreciate me going above and beyond for them. So it's bigger picture thinking, but it really is in everyone's best interest here as we think of the longevity of vision care as a whole. So with that, we get into the actual logistics here. So dropping vision plans, it, I want to say, is clear cut in how you take the approach, but with each carrier, there can be nuances. So we have folks who have made the choice to pull the plug, drop them all at one time. They're like, hey, I'm jumping into the deep end. I'm going to learn how to swim. I've had this practice for 20 years and I no longer want to have to be dealing with all of my accounts receivable, my write-offs, and complaints when my lab orders from Davis and Spectera aren't what they should be. We've seen people do it really successfully and again have that initial hit of losing a certain percentage of volume to patients that I like to refer to as insurance chasers. People that no matter how much of a relationship you have are always just going to want to go somewhere that they can get the best deal, that they're not going to have to spend any money out of pocket. When you pull the plug on all your vision plans at one time, you're really going to get a sense of how many of those patients are in your practice. And it will give you the opportunity to pivot and figure out what you need to do to appeal to the proper demographic who's really going to value the quality of care over just the dollar amount. We have other practices that have chosen to do it one at a time. They want to get an understanding of how does their patient base react when they find out that they're going to get their reimbursement within 30 days of their visit, or that maybe they're spending anywhere from 50 to 200 extra dollars per transaction in your office because you're going to be able to let them know their high prescription count is getting sent to a lab that's going to take really good care of them. Typically, people will start with a plan if they're really nervous that has the lowest amount of covered lives in their office, again, to get a gauge and see, is there any type of iteration that we need to make on our conversation, on the narrative that we're presenting to patients? Do staff need more training? Or they choose to drop VSP because it has the most covered lives in their office and it has a feature that we call assignment of benefit, meaning you can actually accept the out-of-network reimbursement on behalf of your patients at point of service. Only VSP and Cigna are the two plans that offer this feature, so it eases the upfront cost to the patient and it makes the transition a bit easier. VSP plans also typically have the most robust out-of-network coverage. So again, the transition between the two can be a little bit more seamless than when you're dealing with a Davis patient who may not have great out-of-network coverage. So it really just depends on what your office is seeking to gain from this change. And I'll say a few times in this call today, to talk about the specific needs of your practice, really going to recommend getting an individual demo. We know that no two practices are alike, whether you're in a more rural setting and you're not dealing with competition in the same way. You don't have as many in-network competitors, but maybe patients in your demographic are a little more hesitant to pay up front. We'll want to take that into consideration compared to being in a high metropolitan area where you have a lens crafters on every corner. And for this reason, you're like, I don't know if I can drop IMED and be able to manage that change. So we want to take your unique circumstances very seriously as we talk about making this transition because it really, those variables do make a difference. So after we've decided we're going to, cut the cord on all of them or go one at a time, we then have to think about the narrative of informing your current patient base as well as what's going to be our pitch to new patients that are finding us online. So you've got folks who decide to send a generic email blast letting, hey, Davis, patients, our relationship with your insurance has changed. Give us a call to find out what your new coverage will be. Leave it a little bit vague, but also set the stage so that people are are aware before they call in to book their annual visit that, it's not just going to be their $10 copay anymore. There's also people who've just, created a different script or talk track as the patient calls in. We don't want to cut ourselves off at the knees. Again, when you tell people out of network, they assume that means out of benefits. Re-educating patients on how vision plans, which we all know on this call are essentially just a discount plan, how they actually work, is really important in this process. And again, you guys are going to know your patients better than we ever could. So taking in unique circumstances for how conversations in the past have gone versus how they're going to go moving forward is important. And something that I want to address as well is obviously our staff are really important when relaying this message. I like to explain in versus out of network as a passive versus active sales process. When we're in network, a patient calls in, we tell them what their copay is, and then we hope once they get into the practice that we're going to be able to upsell and do all of these things to make that visit valuable revenue-wise. When we're out of network, instead, the active participation or sale comes up front when we're communicating to our patients why we've chosen to be out of network, that we refuse to allow insurance companies to dictate the quality of care that we're able to give. We would rather apologize upfront for the increasing cost than apologize on the back end for the low quality of care that's not a reflection of us as doctors, but as of the insurance companies. So thinking through how we are going to support staff to make that pivot. If you've traditionally always been in network and people are used to the back end upsell, now moving them toward a more active, transparent conversation on the front end, because the great news is after we've had a conversation with patients who now more than ever really care where their money goes. We are wanting to support small businesses, and of everything that's happened in the last year, we want to know that our money, when we are spending it, is going to our local doctors and opticians who are a part of our community, rather than these huge multi-billion-dollar insurance companies that, again, we've seen time and time again, aren't necessarily here for our best interest. So it's something that we want to think about when you consider who's answering the phone in your practice. So that leads us to the finale, I should say, of once we've taken these pieces of the puzzle into consideration, implementing software to make your staff's experience as easy as possible. We've built a program that is really simple. It's a 1-2 step process that is going to, even if you have staff that aren't super tech savvy, it's not going to scare them out of walking down this path. The program is incredibly easy to use. It's more the conversation with our patients that takes a little bit more finesse and time to get used to, which again is included in our services, our customer success team, our support chat. All of those folks are there to enable your staff to not only use the system well, but to talk about the new process in general. So with that, let me move over here to our demo so y'all can see Anagram in real time. When we get into the system, it's going to live alongside our practice management. We don't integrate with any other software at this time. We are a standalone system. So people can essentially think of us as their all-in-one solution for any patient that has a vision plan that you guys do not accept. Maybe it's just Davis patients. You can consider us a Davis out-of-network portal. Maybe it's all of the vision plans. We're going to be able to then come in here for any of those carriers that we're not credentialed with. So first thing that we're going to do when a patient calls in, either returning or new, and says, hey, I've got this insurance, can you help me? We say, yes, we're an open access provider. Let's figure out what your benefits are. Leave it rather vague and open-ended so that we can pull in their eligibility. And once their dollar amounts are in front of us, we can have a more educated conversation about their coverage today. So to add a new patient, let's say Connor has walked into the practice. We'll need his first and last name, his date of birth, his gender, his phone number, and a practice management ID if you want to make it simple to sync the two in terms of tracking. Next, we need to know who their insurance is with. So we're not an I Dream of Genie system. We cannot search all the carriers at once. We wish that we could. We're hoping one day that might change, but as of now, the patient still has to know who their insurance is with. So all the carriers are going to be listed here. For the sake of understanding, we cover the 8 major plans of VSP, Cigna, IMED, Aetna, Blueview, Davis, Superior, and Spectera. So we can send that follow-up information to you if that was a little too quick to write down. For the sake of this call, we go with the demo, and then it's going to ask for just a few other pieces of information in order for us to locate Connor's real benefits in real time. So that will be the last 4 of their social, member ID. For some plans, other plans don't require it, and then their mailing address. So some of this information is needed really just to file the claim, which is why we like to collect it all up front so that we don't have to ask anything from the patient once their benefits are pulled and they've said, hey, of course I'm going to stay here. I want to buy these frames. And then they're on their way. We don't have to ask for anything else on the back end. And then finally, their employer. So once we have this information, we click connect. And this is where it's going to put us into a queue. Our system is doing what only Anagram can do, which is searching through the insurance portals to understand what is Connor owed today. So it takes a typical 1 to 3 minutes for us to access the information. And this is for a few reasons, but mostly because we got to make sure we find the right Connor, and we want to make sure that his information is up to date. So we're seeing his results as it stands right now. So for example, if Connor went down the street the day before to an IMED provider, maybe he went to a Lens Crafters and he used his benefits. So he had coverage, but he's already submitted a claim, or the practice has submitted on his behalf. Our program is going to let you know, hey, he did have coverage, but they're not available anymore. They're going to renew at this time next year. And so that way you really can think of Anagram as your single source of truth. You don't have to worry about staff giving out misinformation. Some Davis and Spectera plans are administered through Medicare and Medicaid, and they actually don't have out-of-network benefits at all. It happens about 10, maybe 20% of the time, depending on your area. And in that circumstance, we want to rip the Band-Aid off, right? We want to be able to tell them, you know what, you actually don't have an out-of-network reimbursement today, but that tells me that your in-network coverage would probably also be very, very low. You would have a very few select frames to pick from, and then you also run the risk of these offices having to use a lab that won't be able to take care of you. So with us today, and then you can talk about different promotional deals that you can offer to patients who may not have any out-of-network benefits at all, so that you don't have to consider that patient a loss. We have all kinds of anecdotal evidence from customers over the years, how just the act of having this conversation with them and letting them know what their vision plan does or does not cover has helped them keep the patient, because again, people want to know where their money is going. And if their employer is paying $5 a month into a Davis plan, they're going to feel a lot more empowered to just pay out of pocket if they understand why their benefits are as low as they may be. So once we've located Connor in the system, we're going to jump in here to calculate his coverage. So it looks like he still has his exam benefit, most of his materials. For whatever the reason, he has used his lens add-on benefits. So if he wanted anti-reflective coating, he wouldn't be able to today because it has already expired. It will renew in September of 2021. So now that we know what we're working with, we just jump into the calculator, essentially use it as a plug and play. So we put in the rate of your cost within the office, 125 for an eye exam. Let's say they've picked out frames at 300 retail and some progressive lenses at 300 as well. So now what we'll do is we'll jump in here to the receipt. It's going to show us that the total cost of this visit for the patient today would be $725, but with a $170 reimbursement, they are going to owe us $555 when all is said and done. So this brings us back to our assignment of benefit feature for VSP and Cigna only. If you are out of network with that plan, you can allow that $170 to be paid directly back to you at the office, and the patient would only pay the $555 today before they leave. On the flip side, for IMED, Davis, Superior, Spectera, that check still has to go to the patient. So in that circumstance, they'll pay you the full amount, the $725 upfront, and the $170 will be written to the patient and receipt and get sent to them within 3 to 4 weeks. Now, because this sticker shock price for people that may be used to an in-network copay can sometimes be a large leap to make, we've added in a global discount feature, which our current customers can attest that when you think about the huge cuts or discounts you're taking when you accept an in-network patient, this global discount feature allows you to go to bat for this patient, be able to demonstrate to them that at, let's say, 20% across the board, you're able to lower their cost in order to explain to them that you're willing to take this cut because you know that you can take better care of them. The thing to think about on the back end in terms of your guys' revenue is, in what circumstance are we ever making $580 per patient on an in-network exchange? If you were to, let's say you're deciding who to drop and you go into your practice management and you see on average per in-network VSP patient, we're making $175. Maybe that does or does not include any chargebacks from the lab. In this circumstance, with the understanding that the patient is going to pay you today and that is how much each exchange is going to be worth, what type of a discount can you administer? Is maybe even 30%, bringing this total to $507, which is more than doubling what you were making before, going to be worthwhile in order to explain and show the patient, maybe just on your first year of being out of network, that you can make this decision and do what's best for them because you aren't tied by the insurance companies. When you're in network, you can't even offer a discount if you wanted to. And in this circumstance, knowing where your overhead is going, you can make that informed decision regarding what makes sense for your long-term growth and the value that you're seeking per patient exchange. So once we have come to an understanding of what type of a discount we're going to administer, how much the patient will receive back from the insurance, then the last step here is filing the claim. So this is essentially a courtesy file on behalf of the patient. If you're out of network without Anagram, you are either filling it out manually with an itemized receipt on their behalf, or you're asking the patient to do that on their own. Problem with that is that it's often really subject to human error, whether you're putting the name in the wrong place, you're forgetting to sign, not adding the date. Any type of little detail is going to make it really easy for any of these insurance companies to deny or reject the claim. And then they send back an explanation to the patient that, oh, your claim was rejected, but it doesn't tell them why. So people assume, oh, it must have been rejected because I actually don't have coverage, which is not the case. They're just, again, insurance companies putting hoops for us to jump through, hoping harder that it is for patients to access their money, the less likely that they will file and do so. So we've made it really simple by creating an electronic way for you guys to submit that will not be subject to those types of errors. We auto-populate the most commonly used codes to make it really simple, but maybe you want to use a different code, the 92004. We'll select it from the list. It's a really easy scroll down, same with the diagnosis. Everything that you type in is going to be accessible for you here. So if you have a new staff member who isn't familiar with CPT codes or familiar with billing, this should make it really easy for them to move through that learning curve because we have everything programmed in here for you. So great standard frames. VSP no longer has the right to know, are you administering Marchand or Luxottica, whatever it might be. They don't have the ability to see that collection of data. We keep it basic with standard frames, standard progressives, and then we'll come down here and maybe we call this, our open access discount. People have done a few different things with this to make it super clear to the patient that they are going to bat for them and that they're able to do this because they are not contracted with their insurance. We then put the total amount that the patient will be paying us here. If you have a demographic that would be, uncomfortable with spending that type of money up front, you can use things like care credit, a few other options to help lower that financial burden up front so that they can make payments over time. And maybe, you're taking your payment from them in installments, totally up to you. And then this is all the information we collected at the very beginning, make sure that it all looks the way we want to. And unlike the insurance companies, we will never market to your patients. We will not reach out to them, try to sell them anything. We want nothing to do with your patients. We just want to give them the best experience by making it really easy for your staff to communicate with them. And that's actually where our chat support comes into play. So if anybody has questions about eligibility, status of a claim, whatever it might be, all they have to do is jump into our internal support here and ask a question. You can think of us as the muscle between the insurance, your patients, and your staff. So no more being put on hold with Davis for 3 hours. We will do that for you, whatever it might be. Our team is here to make the experience for your staff as easy as possible. So once the claim is complete, we click submit, and we bring that experience full circle by sending them a confirmation email saying, hey, claim has been submitted, money's on its way. If you have any questions, you can get in touch with Anagram. Now, often these folks will have a relationship with your office, so you'll still be the one getting a call if 3 weeks have gone by and they're like, hey, I haven't received my reimbursement. And again, all your staff will have to do is jump into the support queue and ask us. Typically, it's a matter of the claim having been submitted or processed, and the check is in the mail, and we'll be able to get that update for you so you can relay that to your patients. All the claims are stored in a database, so you have a paper trail. This is what enables us to do claim status follow-up. If you're blindly submitting out-of-network claims right now, on paper, there's no way for you to manage this type of follow-up, so we do it for you. We'll let you know if a claim didn't get completed, if it needs to be canceled. All of that will prompt you so that you can have a clear understanding at the end of each day, the status of your claims. And then last thing to keep in mind is our reporting system. So maybe, nope, there we go. This is going to give you the opportunity to see how much is each patient out of network in your practice worth. You can compare that to your current in-network fee schedule if you're using that to determine who to drop, and your overall revenue that you've billed through us over the course of time, as well as your conversion rate. Mine's a little wonky because I run fake patients through the system, but think about this as your claims divided by your patients is going to show you your average conversion. Most of our customers convert about 6 to 7 out of every 10 patients when they have this process in place. Traditional out-of-network offices are converting anywhere from 2 to 3 out of 10 when they don't have the ability to pull up their eligibility information. So with that, we've done a quick run through the tool, and now I want to open up the floor to any questions that have come up. Oh, yeah, and thank you for the reminder. To let everybody know who's, again, maybe been in touch with us in the past, in the last few months, we have changed our pricing model. So we understand that, especially for practices that are looking to drop, they're like, hey, I may not have the volume to justify your flat fee subscription. I want to give Anagram a try, but I just don't know if I can make the annual commitment. And we've heard everybody's feedback. And so we're really excited to let everybody know that we've moved to a pay as you grow model. So what that means is now people are going to be paying based on their utilization. If you have a huge flood of out-of-network patients and you're in the program every single day submitting hundreds of claims, you will be charged accordingly. If you only have 1 or 2 Davis patients a month, you're still going to be able to run them through the system and justify the software without being worried that it will come at a loss. So the new fee schedule is $60 a month flat fee. So every month you'll pay that $60, and then you're going to pay 6% of your claimed revenue. So as you start to move up in utilization, that 6% drops to 4, drops to 2. So we're really trying to incentivize everybody here to be super active in the program. The more successful you guys are, the more successful we are, and vice versa. So we really wanted to align incentives and show that you really should only be paying for the program if you're getting great revenue out of it. All right. So question, Anagram seems like a no-brainer. Woo! Do the insurance companies penalize practices who they know have or are planning on signing up with Anagram materials or medical? Great question, and one of the many myths that we've had the privilege of debunking over the last few years. So no, the insurance company has absolutely no ground to penalize somebody in a free market. We live in America. You have the right to make whatever purchasing decisions you want and to run your practice as you see fit. Now, I think that what the question that does come up is like, hey, what would happen if the insurance companies decided they didn't want to offer out-of-network benefits anymore? And so we have a super robust legal team. We did all kinds of market research before even developing the program 4 years ago to get an understanding of what would have to happen for any insurance, vision or medical, to decide they no longer want to offer out-of-network benefits. And the truth of the matter is it would put the insurance companies in a really, really vulnerable position because they use their out-of-network benefits as a lever that they pull to close contracts with employers. So IMED and BSP have actually increased their out-of-network benefit coverage over the last decade because they would go to employers and say, hey, Google, I know you have a contract with IMED, but you really should work with us here at BSP because we have such robust out-of-network coverage that even if your current employees have a doctor that they're loyal to that doesn't accept our plan, they're still going to be able to utilize their insurance with that provider, even though it's going to be out of network. So for that reason, along with all kinds of other policies that have to do with the Cures Act and different, like Medicare and Medicaid laws, the insurance companies are not in a position to ever pull the plug on their out-of-network benefits. And if they did, it would take years, probably 4 or 5 years, to make it through the courts for them to do so. So everybody would have plenty of heads up to be able to plan for that accordingly. But thank you for that question. We do get it asked a lot, and we appreciate everybody's due diligence here because we know vision insurance, it can be messy. I see another question has come in. So just give me 1 second as it loads for me. All right, speaking of price points, do you help guide a practice on those? And the answer is we can help step in and give as much feedback and advice as you guys would like. So we have all kinds of data. We've run millions of patients. I'm talking hundreds of millions of patients through the system since getting started. So we have all kinds of information on what will work and what may have a lower conversion rate, but a higher dollar amount. So getting an understanding of your goals. Are we looking to maximize cost or value per patient, or are we wanting to make sure that our books stay full? So we're offering a deeper discount, especially for, let's say, the first year as we make that transition, so that we can continue to cement that relationship. And maybe over time, the discount goes from 30% to 20% to 10%. We can absolutely offer that type of feedback during our customer success training. And we also have some relationships with consultants who we've been working with for years who've have a lot of experience in helping people make the transition. So yeah, some folks want to do it all on their own, and we totally support that. If you're looking for a little bit more hand-holding, that is covered in our cost, and we're here to support you in that as well. Oh, hey, Rhonda, I see you. Okay. There is an insurance in my area that charges the patient nothing for a Verilux Comfort. How do we now tell them they owe, and how do we know their reimbursement? I'd be interested to know what that insurance plan is. And obviously that's a super fair concern, right? If they have a plan that gets them a really high end lens for free, and now they're going to be spending money out of pocket for that same material, it really will come down to explaining to your patients why your relationship with the material and with their insurance is different. I'd need to know a little bit more about where you're located to be able to speak to it more coherently, but I would say, yeah, if it's a local insurance in Pennsylvania, I probably know which one you're talking about, and those types of nuances can be tough. And if your practice is entirely made up of that insurance, you would be truly taking a leap of faith and hoping you have patients that are more loyal to their doctor than they are to their copay. It really just comes down to the contracts that they have negotiated and put in place. And it can get a little bit tougher, I would say, in that circumstance. If they make up a huge amount of your patient base, it's worthwhile to start surveying your patients, get an understanding from them what would be their threshold of cost out of pocket to maintain their relationship with you, so they didn't have to go find a new doctor. Have you been established, been around for 5, 10 years? Are you a brand new office and trying to use this plan as a way to grow your patient database? Those are some unique things that you'd want to think through and talk to our team about. But I can still tell you that we've got a lot of customers in smaller states with local plans where this is the circumstance, that are dealing with like TRICARE or Humana. And if they go in network, they get a material completely covered, but in their office, they're going to have to pay maybe $100 out of pocket for it. And they're still managing to educate, empower, and keep their patients in their practice. It just does take quite a bit of thought up front, so that we're going about it really diligently. But that's a really good question, and one that I would encourage you to get in touch with us so we can think through it. Oh, great, Rhonda. Excited for your demo. Make sure you bring this up in the beginning of your call, so our rep can really dig in with you. And appreciate your time for being here and really investing. It'll be worth it long run. And maybe people are wanting to hold off on questions because they have something really particular to their practice. Totally understand. Again, encourage y'all to come in and get a one-on-one demo so that we can, let's say in the calculator, put in your unique price points, really talk about the specific plan in your area, your patient demographic, and incorporate that into the decision-making process if going out of network is something you're considering. But with that, we have just a few minutes left. So anybody that feels they've covered all the bases here in our call can feel free to drop off. If anybody else has questions, again, I've got time. Please keep them coming. We're so grateful for our relationship with Cherry. Everyone that works with them just has nothing but incredible things to say about their reps, their lab work. As Cherry continues to grow and outpace pretty much every independent lab on the market, they're just pouring their profits back into their equipment, back into the quality of service that they can provide you guys. And for that reason, we see that Cherry offices perform better with Anagram. They understand the importance of value and the quality over quantity game. And it really does make a huge difference when you have vendors across your organization supporting you to do what feels best as a doctor for your patients. So again, just really want to thank everybody for jumping on today, for working with Cherry, for keeping the integrity of vision care growing and moving forward, because it's in everybody's best interest here, and we're really grateful to be a part of it. So I think at that, we will call it a day. Appreciate everybody's time and hope that we get a chance to speak to y'all again in the future.